So welcome to another session on the various topics in pediatric surgery. So today we'll be discussing about a very important topic called neck cysts and sinuses. Now, so there are a wide variety of neck cysts that are noted in children. They can either be acquired or congenital. Most common ones are those which arise from a persistent thyroglossal duct or from brachial anomalies. They may not always be present at birth, mind you. They can manifest themselves at varying age groups, and a careful history and examination is key to identify the type of cyst or a sinus or a fistula. Understanding local anatomy is very important with regard to identifying its etiology, its course, as well as excision. Now, embryology is an essential topic as far as pediatric surgery is concerned because everything that we do has a bit of embryology in it. Actually, not a bit, more than a bit of embryology in it. So, it is never more evident than with neck cysts. So, neck is a component which has, during evolution, neck has multiple structures developing at the same time. So, embryology of the neck is quite complex, to say the least. So, let's now briefly discuss regarding the embryology of the neck and its derivatives. Now, the neck develops in a developing fetus as an area between the stomatodium as well as the developing pericardium. So, this space between the stomatodium and the pericardium elongates or increases to form the neck. This increase is brought about by the descent of the periheart and also by the formation of mesodermal pouches or mesodermal thickenings, which are called as pharyngeal arches. Now, you find that the pharynx, which develops from the cranialmost portion of the foregut, is actually funnel shaped. And funnel shaped, not only is it funnel shaped, it is also compressed. It is compressed dorso-ventrally, that is anteroposteriorly. That's how it's compressed. So, it's compressed dorso-ventrally and it has two lateral walls, as you can see here, dorsal surface and a ventral surface. So, that's how it is. So, this compressed pharynx or upper end of the developing foregut tends to have three important layers. It has an outer ectodermal layer, an endodermal layer, and a middle mesodermal layer. So, this mesoderm, this area is formed by the mesoderm. And you have here, this is the endodermal layer and this is the ectodermal layer. So, this mesoderm orients itself within the pharynx, developing pharynx, as bars. And this bar extends dorso-ventrally. It extends dorso-ventrally and it is present in a sequence craniocaudally. So, this bar is what forms a pharyngeal arch. So, you find that this mesoderm develops from two important components of the mesoderm, that is, it forms from the paraxial mesoderm and the lateral plate mesoderm. So, with this regard, so you find that this bar that is present, there are 6 bars that develop. So, each of it is called the first arch, the second, the third, fourth, fifth, and the 6th arch. The 5th arch soon disappears after formation. So, in the end, we are left with only 5 arches. So, these 5 arches are important as they result in the development or they contribute to the development of many vital structures in the head and neck region. The first and the second arch are the first to develop and they contribute in no mean terms to the development of the anterior or the closure of the anterior neuropore. So, stabilization and closure of the anterior neuropore is also contributed to by the first and second arch. Now, so like I told you, this arch has an endodermal component which is denoted by red here and an ectodermal component denoted by blue here, and the green is the mesodermal component. So, this endodermal component has outpocketings which are called as pouches or endodermal pouches or pharyngeal pouches. The ectodermal or the blue areas like you see here form depressions called clefts, and these are called ectodermal clefts, also called as pharyngeal branchial clefts or pharyngeal clefts. Now, so as you can see here, in these clefts and pouches are located between pharyngeal arches. So, you have first, second, third and fourth pouches, first, second, third, fourth clefts or pharyngeal clefts. Now, each arch, like I told you, each arch is a bar-like structure. So this bar, how it looks like in a coronal section. So if I take each arch and have a look at it, so each arch will have its own nerve, will have a vascular branch from the aorta or an aortic arch, will have a cartilaginous component, will have a skeletal muscle component to it. Now, so the nerve component is different for each arch, and the aortic arch component is also different. So each arch has its own nerve supply, contributes its own nerve, and the muscles which are supplied by this particular nerve, a cartilaginous compound which gives rise to skeletal muscle derivatives, and aortic arch. A very important point to be noted is that the mesoderm that is located, like I told you, between the two ectodermal and endodermal components, this green color mesoderm that you can see here, also has within it neural crest cells. So these neural crest cells contribute to the skeletal component of each and every arch. So coming on to each and every component. Now let's first discuss regarding what are the cartilaginous components. So the cartilage of each arch contributes to various bony elements in the head and neck region. So the cartilage of the first arch is also called mandibular arch. The cartilage of the first arch is called Meckel's cartilage. Now Meckel's cartilage can be divided into two important components. One is a dorsal component, another one is a ventral component. So the dorsal component of the Meckel's cartilage leads on to the formation of the malleus and incus. Those are the small bones in the middle ear, as well as to the wing of the sphenoid bone or spine of the sphenoid bone. So the dorsal aspect of Meckel's cartilage gives rise to the spine of the sphenoid bone, to the incus and malleus, whereas the ventral portion of the Meckel's cartilage is surrounded by mesenchyme to form the mandible. So you find that this ventral aspect of the Meckel's cartilage is actually encased within the mesenchyme. It gets absorbed into the mesenchyme to form what is called as the mandible, So this area between the ventral and the dorsal aspects of Meckel's cartilage completely disappears, forming only an outer sheath which is called as sphenomandibular ligament. As you can see here, this is a sphenomandibular ligament. Now, so how does this bony formation occur? Okay, so this is how the bony formation occurs. So not only this, you find that the first arch, the mesenchyme of the first arch, can also have ventral and dorsal components. So the mesenchyme, other than the cartilage, the mesenchyme itself gives rise to the bones of the maxilla. The ventral aspect, it gives rise to the mandible. Like I told you, it encases the Meckel's cartilage. The dorsal aspect or dorsal mesenchyme of the first arch gives rise to the maxilla, premaxilla, zygomatic process, palatine process, etc. And of course, the sphenoid. And a portion of the temporal bone is also formed from it. So these are all derivatives of the mesenchyme of the first arch. Ventral aspect is a dorsal aspect. The ventral aspect of the mesenchyme of the first arch gives rise to the mandible. Like I said earlier, it encases the Meckel's cartilage. Now, what about the second arch? Now, second arch is called hyoid arch because a portion of the hyoid bone is formed from it. And the cartilage of the second arch is called Richard's cartilage. So, Richard, R-E-I-C-H-E-R-T'(S), Richard's cartilage. So, this Richard's cartilage gives rise to various important structures. It has a ventral and a dorsal component. So, the dorsal component gives rise to the styloid process as well as to the stapes, which is again a component of the middle ear. The ventral aspect of the Richard cartilage gives rise to the smaller horn of the hyoid bone and the superior aspect of the body of the hyoid bone. The area between the ventral and the dorsal aspects or dorsal components of the Richard cartilage again disappears, forming only a membrane or a ligament which is called as the stylohyoid ligament. So to summarize again, the hyoid arch or the second arch, the cartilage of the second arch is called Richard's cartilage, R-E-I-C-H-E-R-T, It has a ventral and a dorsal component. The dorsal component gives rise to the stapes and styloid process. The ventral component gives rise to the superior aspect of the body of the hyoid bone and the smaller cornua of the hyoid bone, also called as the lesser cornua of the hyoid bone. And also the area between the ventral and the dorsal aspects of the cartilage disappears, leaving behind only a membrane or a ligament called as a stylohyoid ligament. So, skeletal components of the second arch can all be denoted by the term S. So, what are the derivatives, skeletal derivatives of the second arch? Second, S. So, S includes stapes, it includes styloid process, includes this smaller cornua of the hyoid bone, superior aspect of the body of the hyoid bone, and the stylohyoid ligament. So, those are the skeletal derivatives of the second arch. Now, the third, fourth and sixth arches, the fifth one I told you disappears. So, the third arch gives rise to the greater cornua of the hyoid bone, the inferior aspect of the body of the hyoid bone. The fourth and the sixth arches gives rise to the cartilages of the larynx. So, it includes the thyroid cartilage, the cricoid cartilage, the corniculate, cuneiform, arytenoid, as well as gives rise to the thyrohyoid ligament, epiglottis. All these are derived from the fourth and sixth pharyngeal arches. Now, like I told you earlier, each arch has its own nerve, arterial supply, has its own skeletal muscle component and a cartilage or a skeletal component. So, we discussed about the cartilaginous and the skeletal component before. Now, we will be discussing about the nerve of each arch, artery of each arch and the muscles that are derived from each arch. Now, it is one important thing is to be noted with regard to the nerve of each arch. So, like I told you earlier, so this is an arch. So, a pharyngeal arch has a trough. Okay, this is a trough. So, a trough here and a projection here. So, on the upper end of each pharyngeal arch, you have the nerve of the pharyngeal arch. So, at the cranial aspect of each pharyngeal arch is located the nerve of the arch. Okay. So, in lower animals, what happens is, in addition to the main nerve of each arch, there is also an accessory nerve which arises from the nerve of the subsequent arch. For example, this is all in smaller or in lesser beings, or lesser, say, not in humans, these are all in other animals. So, in other animals, what happens is, other than the main nerve of each arch, there arises another accessory nerve from the subsequent arch. For example, the first arch can receive an accessory nerve fiber from the nerve of the second arch. So, all this is seen in smaller beings. In humans, such a phenomenon usually does not exist. Only one arch has a dual nerve supply, that is, it has a nerve supply from the subsequent arch. So, this is the first arch. Only the first arch has a dual nerve supply. Now, since the nerve of each arch is located in the cranial aspect of that particular arch, these are called post-traumatic nerves. Trauma means a trough or a trench. That's what a trauma means. Post-traumatic. So, this is a trench. So, what comes after the trench is post-traumatic. So, post-traumatic region is where all the main nerve of each arch is located. So, a nerve of an arch is a post-traumatic nerve. Only the first arch receives a supply or a small branch from the second nerve of the second arch supplying it, which is called as a pre-traumatic nerve. And this pre-traumatic nerve is the chorda tympani. Chorda tympani, which is responsible for special sensation of the anterior two-thirds of the tongue. So, this is an important point to be remembered. You find that in humans, you have only a post-traumatic nerve. That is, there is only a single nerve to each pharyngeal arch, except for the first arch, which can have an accessory nerve from the nerve of the second arch. And this accessory nerve is called a pre-traumatic nerve, And this pre-traumatic nerve is the cauda tympani, which is a branch of the facial nerve. Okay. Now, there are certain controversies with regard to this. There are two important nerves which are also said to be pre-traumatic, but they are not considered to be pre-traumatic nerves. One is, some people, some individuals or some studies state that you have a tympanic branch arising from the glossopharyngeal nerve, and the auricular branch of the vagus nerve are said to be the pre-traumatic nerves of the second and the third arch. But then this is still under study and it is not proven. So as of now, for all purposes, academic and otherwise, only the first arch has an accessory nerve supply or a pre-traumatic nerve from the subsequent nerve, which is called as the cauda tympani. This pre-traumatic nerve is the cauda tympani. So only the first arch has a dual nerve supply. The other arches have only a single post-traumatic nerve, which is located on the cranial end of each pharyngeal arch. Let us discuss what are the individual nerves of each arches, artery of each arch, and the muscles of each arch. Now, like I said earlier, the artery of the first arch is a mandibular branch of the trigeminal nerve, which is both motor and sensory. It also receives a pre-traumatic branch, like I said earlier, from the facial nerve, which is the cauda tympani, and this cauda tympani is responsible for taste sensation involving the anterior 2/3 of the tongue. Artery of the first arch is the maxillary artery, are again the muscles which are supplied by the mandibular branch of the trigeminal nerve, which includes the muscles of mastication like masseter, medial pterygoids, lateral pterygoid, temporalis, anterior belly of digastric, tensor tympani, tensor palati. All of them are migratory except for tensor tympani. One important point to be remembered regarding the muscles of each arch is that the muscles of each arch always follow their nerve supply. So their insertion and origin may not always correlate with the skeletal structures developed from that particular arch. For example, all the muscles which are developed from the first arch will have the nerve supply from the nerve of the first arch, but they may not always have an origin or insertion from the skeletal derivatives of that particular arch. It might vary. Sometimes it can get inserted or may originate from the skeletal structures developed from the second arch. We don't know. So it is not constant that each muscle which develops from, say, the first arch should have its origin and insertion from a skeletal element of the first arch itself. It can arise, it can originate or insert itself into the skeletal structures developed from the second arch also. Okay, but the nerve supply is absolute. So muscles of the first arch will have its nerve supply only from the nerve of the first arch. So coming on to the nerve of the second arch. The nerve of the second arch, which is called the hyoid arch, is the facial nerve. The facial nerve and the artery of this second arch is the stapedial artery, which is the predominant artery, and another accessory artery is the hyoid artery. The muscles of the second arch include the muscles of facial expression. Along with it, you have stapedius, stylohyoid, and the posterior belly of digastric. So muscles of facial expression include orbicularis oculi, orbicularis oris, zygomaticus, buccinator, nasal muscles, etc. Levator labia superioris, levator anguli oris, and the auricular muscles. Okay. Similarly, the third arch. The nerve of the third arch is called the glossopharyngeal nerve. And the artery of this third arch is a common carotid artery and an internal carotid artery. So what is artery of each arch? So how do you get the artery of each arch? So the artery of each arch itself is a separate topic altogether. So during the development of the pharynx, you have two aortas to be remembered. You have a dorsal aorta and a ventral aorta. And in between the dorsal aorta and the ventral aorta, you have the aortic arches. So these aortic arches give rise to the various arteries of each arch. Okay. So the artery of the third arch is the common carotid artery and the internal carotid artery. There is only one muscle derived from the third arch, which is the stylopharyngeus muscle. Fourth arch. The nerve of the fourth arch is the vagus nerve and the branch of the vagus nerve called the superior laryngeal nerve. So the nerve of the fourth arch is the superior laryngeal branch of the vagus nerve. And the artery of the fourth arch is the arch of aorta, on the left side and the subclavian artery on the right side. And the muscles of the fourth arch include the cricothyroid, muscles of the pharynx, intrinsic muscles of the soft palate except for tensor palati. Okay. So, as we know, tensor palati derives its muscle of the first arch. So, except for tensor palati, all the other intrinsic muscles of the soft palate, muscles of the pharynx and the cricothyroid are all derivatives of the fourth pharyngeal arch. Next is the sixth pharyngeal arch. The nerve of the sixth pharyngeal arch is the recurrent laryngeal nerve, and the artery of the sixth pharyngeal arch is the ductus arteriosus on the left side and the pulmonary artery on the right side. All intrinsic muscles of the larynx except for cricothyroid are derived derivatives of the sixth pharyngeal arch. So, this is very important. Now, so the arches give rise to all these structures. So, like I told you, there are ectodermal components. There is an ectodermal layer to the arch and there is an endodermal layer. So, this is the ectodermal layer. Like I told you, it forms clefts, and endodermal layer forms pouches. So, what happens to the ectodermal layer? So, the ectodermal layer, like I said earlier, only the first dorsal aspect of the first cleft or first pharyngeal cleft persists. That gives rise to the external acoustic meatus, external auditory meatus as it's called, and also to the cuticular layer of the tympanic membrane. Both these are derived from the ectopic, from the ectodermal clefts, also called as the pharyngeal cleft. Only the dorsal aspect of the first pharyngeal cleft remains, gives rise to structures. So, this dorsal aspect of the first pharyngeal cleft gives rise to the external acoustic meatus as well as to cuticular layer of the tympanic membrane. At the junction between the first and the second arches, that is the cleft located at the junction between the first and second arch, these can have hillocks or small mounds, and these mounds fuse together to form the pinna. So, pinna is another derivative. Sometimes you can have epibranchial swellings. So, these epibranchial swellings located in the first branchial cleft can give rise to sensory ganglions of cranial nerves 5, 7, 9 and 10. This is very important. Other ectodermal derivatives of the first cleft would include skin involving the tragus, would involve the skin involving the maxilla, mandibular region, zygomatic region, etc. Okay. So, the mesenchyme of the second pharyngeal arch, it can overgrow, protrude and overhang this third and the fourth pharyngeal arches or clefts, can overhang the third and the fourth pharyngeal cleft. This mesenchyme can fuse with the epicardial ridge, okay, creating a small gap here which is called as a cervical sinus. This cervical sinus disappears normally. If it is present or persistent, it leads on to second branchial cleft anomalies like branchial cyst or branchial sinus if it is communicating to the ectodermal component or communicating externally. So, to emphasize again, the mesenchyme of the second pharyngeal arch can overhangs the second and the third and the fourth pharyngeal clefts or branchial clefts, fuses with the epicardial ridge, isolating the second and the fourth pharyngeal clefts from the outside, creating a space called as the cervical sinus. This cervical sinus obliterates or gets obliterated completely. If it persists, it leads on to the development of what is called as the branchial cyst or a branchial sinus if it is communicating externally. So, these are the derivatives of the pharyngeal cleft or branchial clefts. Now, pharyngeal pouches, like I said, there is first, second, third, fourth and a possible fifth pharyngeal pouch. So, it is to be remembered that a pouch, pharyngeal pouch, is a main contributor to the development of the tongue. So, initially itself, it has two important components. It has a ventral component and a lateral component. Ventral component invariably leads on to the development of the tongue, contributes to the development of the tongue. The lateral component divides again into two. It divides again into two. It's called a ventral wing and a dorsal wing. So, this except for the first pharyngeal pouch. In all structures except for the first pharyngeal pouch, you have a ventral derivative and a dorsal derivative from each pharyngeal pouch. The first pharyngeal pouch, the ventral derivative completely gets obliterated. Only the dorsal derivative or dorsal wing of the first pharyngeal pouch persists. This dorsal wing of the first pharyngeal pouch forms a diverticulum called as, along with the dorsal component of the second pharyngeal pouch, which is called as a tubotympanic recess. This tubotympanic recess has a distal end and a proximal end. So the distal end of the tubotympanic recess elongates itself and it can form what is called as the medulla. The other end of the tubotympanic recess forms what is called as the auditory canal, also called as the eustachian tube. So to summarize, the first pharyngeal pouch, the ventral wing of the first pharyngeal pouch completely gets obliterated by the developing tongue. The dorsal aspect or dorsal wing of the first pharyngeal pouch gives rise to the tubotympanic recess. This tubotympanic recess, one end of the tubotympanic recess gives rise to the medulla, the other end gives rise to the eustachian tube. Similarly, the second pharyngeal pouch. The second pharyngeal pouch again has a ventral wing and a dorsal wing. The dorsal wing of the second pharyngeal pouch contributes to the development of the tubotympanic recess. The ventral wing of the second pharyngeal pouch gives rise to the palatine tonsil and the tonsilla fossa. The third pharyngeal pouch again has a ventral and a dorsal component. So the ventral component gives rise to the thymus, whereas the dorsal component gives rise to the inferior parathyroid glands. Fourth pharyngeal pouch, again ventral dorsal. Ventral aspect can contribute to the development of the thyroid gland and annulage a portion of the thyroid gland. The other component gives rise to the superior parathyroid glands. The fifth pharyngeal pouch is said to give rise, also called ultimobranchial body, is said to give rise to the parafollicular C cells which secrete calcitonin. Okay. Now, this is an important point. We find that thymus and the inferior parathyroid glands are developing from this third pharyngeal pouch. Inferior parathyroid glands have to descend down to attain its position, normal position, along with the thymus. That is why it is very important that in cases of primary hyperparathyroidism, wherein you can have parathyroid hyperplasia, when you go in to operate on such case, it is very important that we need to look for the presence of accessory parathyroids. And one of the commoner sites of accessory parathyroid is the parathymic region in children, because you could have ectopic parathyroid glands in the parathymic region. Okay, similarly, you can have thymic rests noted within the thyroid gland because of a abnormality involving the descent of the thymus. So it is very important. This is clinically a very important point. So coming on to the development of the thyroid. So a thyroid develops itself from the floor of the pharynx from a point called as a foramen cecum. From the foramen cecum, you find that a small diverticulum develops which becomes bifibbed or bilobed. This descends down, comes down and then develops into the thyroid gland. So this diverticulum or duct that is formed is called as a thyroglossal duct. And you have the thyroid gland, which is a bilobed structure. So this thyroid gland also receives some contributions, like I said earlier, from the fourth pharyngeal pouch. Now, parafollicular C cells also are developed from the fifth pharyngeal or ultimobranchial body, and along with that, normal follicles also develop subsequently. So, functioning of a thyroid gland depends upon development of many adjacent structures. Okay. So, this thyroglossal duct, what happens is, once a thyroid is formed, this thyroglossal duct has to break down. If it persists, then it leads on to what is called as a thyroglossal duct cyst. A very important point to be noted here is the relation of the thyroglossal duct to the developing hyoid bone. So, like I told you, as the thyroid descends down, it is in close proximation with the developing hyoid bone, the centrum of the developing hyoid bone. Hence, you find that in a thyroglossal cyst, this is very important treatment-wise. We'll be discussing about it later on. Okay. Now, so this is a pathway of migration of the thyroid gland. A portion of the thyroglossal duct can persist over the thyroid lobe as a pyramidal lobe. Okay. Anywhere else, if it persists, it forms a cyst, and that cyst is called a thyroglossal duct cyst. Okay. The thyroid descent itself can get arrested anywhere along its course, resulting in the formation of an ectopic, either lingual thyroid or an ectopic thyroid. So, coming on to one of the most common cysts noted in the neck, it is a thyroglossal duct cyst. It is the most common midline cervical anomaly, and its relation to the hyoid bone is very important. It can be adjacent to the hyoid bone in 60% cases. In 24% cases, it can be above the hyoid bone. It can be below the hyoid bone in 13% cases. It moves with deglutition and on protrusion of the tongue. So, this is a classical example of a thyroglossal cyst. Okay. Now, even though we say it's a midline cyst, 40% cases, it can be just lateral to the midline. It is usually a cystic swelling with a smooth surface and pinchable skin. Sinuses can occur, but it is to be remembered that a thyroglossal sinus is always acquired. So, it occurs secondary to infection, breakdown, or post incision and drainage. Suppose this particular cyst, okay, gets infected. Then what happens? It forms an abscess. This abscess can rupture, form a sinus. It can, we might have to do an incision and drainage, and that can result in the formation of a sinus. So, a thyroglossal duct sinus is always acquired. It is never congenital. Okay. So, how will a cyst get infected? Cyst gets infected because you find that its origin is from the tongue or from the foramen cecum. Foramen cecum is located at the junction between the anterior 2/3 and the posterior 1/3 of the tongue. So, because of the communication with the oral cavity, there is increased chances of descending infection into the cyst, causing an infection of the thyroglossal duct cyst. And this infection can lead on to breakdown of the cyst or might require an IND, resulting in the formation of a sinus. Commoner organisms include Haemophilus influenzae, staph, are usual organisms which are contributing to the development of an abscess. Sometimes these thyroglossal duct cysts can be intralingual in 8% cases. So, these intralingual thyroglossal cysts are known to produce airway obstruction. The duct, a cyst itself has ductal epithelium in it. They can contain solid thyroid tissue. Okay. One very important point to be noted is that any child with a thyroglossal duct cyst always has to be investigated with an ultrasonogram to look for the presence of normal thyroid. Sometimes the thyroglossal cyst could be the only existing normal functioning thyroid. The child may not have a normal thyroid gland. The thyroglossal cyst might be the only functioning thyroid tissue in the neck. So, which makes it very, very complicated. Okay, only functioning thyroid tissue. So, in such a case wherein you find that you do an ultrasound, there's only the cyst that you thought was a thyroglossal duct cyst is the only functioning thyroid tissue in the neck. There is no normal thyroid. We cannot go ahead and do an excision of the cyst. Then we will make the child completely hypothyroid. These children have to be evaluated with a thyroid function test, following which they have to be taken up for a radioiodine uptake scan. So, again that will confirm if this is the only functioning thyroid tissue in the neck. If it is the only functioning thyroid tissue in the neck, it should not be removed. Okay. The child in such cases will usually be hypothyroid because the thyroxine secreted by this small functioning thyroid tissue is not sufficient to maintain normal homeostasis. So, these children are usually hypothyroid. So, on supplementing with L-troxin, you find that the cyst might actually decrease in size, because this increase in size could be because of TSH stimulation. So, once you give the child, supplement the child with L-troxin, the TSH secretion is suppressed and you can have a decrease in size of the cyst, thus providing some degree of relief from whatever symptom it has been causing. So, indication for surgery in a thyroglossal duct cyst would be all of these cases have to be operated because of increased chances of infection. Another very important complication in thyroglossal duct cyst is malignant conversion, and the most common malignancy is a papillary carcinoma. Even though papillary carcinoma was initially said to occur only in adulthood, small anecdotal cases have been documented even in children. So, we proceed with what is called as a cyst trunk operation. So, a cyst trunk operation, an incision is made, a transverse incision is made, neck crease incision is made over the cyst with the child positioned with a head ring, neck extension and head turned to a neck extension like a rose position. So, incision is deepened, the strap muscles are split, including the sternothyroid and the thyrohyoid. The cyst is identified, the cyst is dissected up till the hyoid bone. The superior aspect attachment, superior and inferior attachments of the hyoid, muscular attachments to the hyoid bone are divided, which would be the hyoglossus above and the mylohyoid below. So, these are divided. The centrum of the hyoid bone is freed and it is divided along with the cyst. The remnant of the cyst can always be transfixed. Now, this is one surgery where the anesthetist contributes to a large extent in the completion of surgery. Ideally speaking, the anesthetist has to push the foramen cecum down so that the cyst can be removed along with the hyoid and a cuff of the mylohyoid. So, that would bring about complete removal of the cyst and the tract, which may not always be possible. In an infected cyst, primary excision or excisional cyst should not be attempted because there is very high chance of recurrence. Such an infected cyst, we proceed with an incision and drainage of that particular cyst. Even otherwise, routine excision of the cyst has a recurrence rate of almost 10%. In case of recurrences, we might have to go for a more extensive excision, sometimes removing the portion of the strap muscle, a larger portion of the hyoid bone along with it. Very important point to be remembered in infants is that the hyoid bone and the thyroid cartilage might be in close approximation to each other. So, in very small infants. So, in such cases, injury to the larynx as you are dividing the hyoid bone is very common and has to be thought about. Branchial cleft remnants, they are the second most common types of cysts on sinuses in the neck. They can be either a cyst, sinus, fistula or even cartilaginous remnants. Cysts are usually have a mucosal lining or an epithelial lining. There are two important syndromes which are associated with branchial cleft remnants. One is BORE. BORE is branchio-otorenal syndrome. BOF is branchio-orofacial syndrome. So, branchio-otorenal syndrome would include branchial cleft remnants with ear abnormalities and renal abnormalities. Branchio-otofacial includes again ear anomalies along with facial cleft disorders. So, among the branchial cleft remnants, the second cleft remnants are the most common. So, these are usually externally located along the anterior border of the sternocleidomastoid and internally might open into the ipsilateral tonsillar fossa, usually posterior to the anterior pillar of the tonsil. Depending upon how it manifests as a cyst or a sinus or a fistula, the position of these remnants will vary. Generally, it is usually located along upper one-third of the anterior border of the sternocleidomastoid, whereas sinuses are located in the lower one-third of the anterior border of the sternocleidomastoid. It is related to three important structures. One is glossopharyngeal tract itself is related closely to three important structures. One is glossopharyngeal nerve, hypoglossal nerve and the carotid. The epithelium, these are lined by epithelium. Cysts are said to be more common than fistulas, even though in clinical practice fistulas are very common. Most commonly, they manifest themselves as asymptomatic, non-tender swelling in the neck. Children can present with acute infection, in which case the swelling becomes tender, erythematous, and associated with constitutional symptoms like fever. These cysts might change in size based on whether the child has a respiratory infection or not. If the child has a respiratory infection, these cysts might increase in size. If it is a sinus or a fistula, they can be discharged from these sinuses also. There are four important types of second branchial cleft anomaly. First is a tract which is superficial in nature. It is present deep to platysma but does not reach up to the carotids. Second type, the tract itself is pretty deep to sternocleidomastoid. It is anterior or posterior to the sternocleidomastoid and the carotids. Third is it passes between the bifurcation of the carotid. Fourth type of branchial sinus or fistula would be the tract passes medial to the carotid sheath, very closely related to the pharynx, sometimes opening into directly or very closely related to the pharynx. So, most common manifestation in infants is usually a sinus with discharge. The tract by itself might be palpable, and sometimes on swallowing we get what is called as a thug sign. There can be associated stridor and dysphagia in severe cases. Malignancy in the form of bronchogenic carcinoma is a documented entity. Early surgical excision by 3 to 6 months is recommended, and surgical excision is to be complete, and it has to be done by placing what is called as a step ladder incision. The tract has to be identified and dissected up to its innermost component, sometimes right up till the pharynx. During excision of the tract or dissection of the tract, the care must be taken not to damage the carotids, also to ensure that there is no injury to the glossopharyngeal nerve and the hypoglossal nerve. Sometimes the tract may be very thinned out, so while dissecting along the tract, you might snap the tract, in which case recurrences are very common. So, even with complete excision, you might have recurrences, but partial excision of the cyst results in very high incidence of recurrences. First, cleft anomalies. So, first cleft anomalies are extremely rare anomalies, usually common among females, and they can be located anywhere between the external auditory canal, they extend between the external auditory canal and the submandibular region. Most important differential diagnosis for first cleft anomaly is a preauricular pit. There is a very close association of these anomalies with the parotid gland and the facial nerve. Very important. So, there is something called a work classification which subdivides first branchial cleft anomalies into two different types. So, type 1 is almost like a duplication of the membranous external auditory canal. These are ectodermal in nature and located lateral to the facial nerve. Type 2, as you can see here, these are both endodermal and mesodermal in origin, and they are located medial to the nerve, and their presence can be either preauricular, auricular, or even postauricular. The external opening of these sinuses are usually located below the angle of the mandible. Invariably, there will be a communication with the membranous portion of the external auditory canal in such anomalies, first cleft anomalies. The treatment of choice in such anomalies is to go ahead with a complete excision. During excision, facial nerve injury, particularly in infants, facial nerve injury is very common and has to be prevented. There are some authors who recommend the first thing to be done in such cases to go and identify the trunk of the facial nerve and to proceed with a superficial parotidectomy in order to reduce facial nerve injury along with excision of the cyst. So, as the cyst or the sinus or anomaly is being excised, a portion, the membranous portion of the external auditory canal might also have to be excised. Sometimes we can have extension of this into the tympanic membrane, which might require a reoperation at a later date. Third and fourth branchial anomalies are extremely rare, and they usually present themselves in the neck, usually on the left side. They present as sinuses or infected cysts, most commonly as neck abscesses, with recurrent neck abscesses a common manifestation of third and fourth branchial anomalies. The internal opening is usually into the pyriform sinus. Third arch anomalies or tract, third arch sinuses usually arise along the anterior border of the sternocleidomastoid, most commonly on the left side. They pass close to the internal carotid artery and glossopharyngeal nerve, penetrate the thyroid membrane above the internal branch of the superior laryngeal nerve, that is towards the upper pole of the thyroid, very closely related to the upper pole of the thyroid, ipsilateral thyroid lobe, and then it enters into the pyriform sinus. Okay, so this is a third pharyngeal arch fistula. Now, documentation of a pyriform complete fistula in a third pharyngeal arch is very difficult. So, if it has to be documented, there are different techniques. I will be discussing about it later. Now, fourth branchial arch fistula is only been hypothesized. There is only a theoretical explanation to it because clinical documentation of a fourth branchial arch fistula is not there. It is not commonly seen at all, in fact. So, if a fistula is present, usually the course of the tract would be it winds around the subclavian artery on the right side, goes up and then opens itself. It's closely related to the hypoglossal nerve and opens into the pyriform fossa. On the left side, it can wind around, the tract can wind around the arch of aorta and can again is related to the hypoglossal nerve and the rectolaryngeal nerve and opens itself into the pyriform fossa again. But then again, fourth branchial arch fistula is only theoretical. It's only a theoretical documentation. No complete fourth branchial arch fistula has been documented. So common presentation, like I told you, are recurrent neck abscesses, recurrent respiratory tract infections, sometimes tenderness of the thyroid, because I told you it is very closely related to the upper pole of the thyroid gland, ipsilateral thyroid lobe. Tenderness of the thyroid is a very common clinical finding. So hence, the differential diagnosis for it would be a suppurative thyroiditis. A contrast esophagogram can give us an idea regarding the fistulous tract as such, or an MRI fistulogram can be tried. The idea is to go ahead and completely excise the tract, which might require removal of the ipsilateral thyroid lobe also. Because if we don't remove the ipsilateral thyroid lobe, there is very high chance of recurrence. One very important problem associated is that when you go close to the pyriform sinus, the pharynx might get opened up, which makes it very difficult because the muscle cover of that particular region, there is no buttress muscle cover in that region. So sutures that you put in that pharynx might open up and cause a fistula or leak of saliva or milk. So that is one common complication that can occur during post-surgical excision of a complete third arch fistula. So hence we might leave behind a small portion of the tract close to the pyriform fossa. We don't leave behind too much of a tract and we don't go too close to the pyriform. Another common cyst in the neck is a dermoid cyst. So these are basically caused because of elements which are trapped during fusion of the anterior wall. They contain ectodermal and mesodermal elements and there are no endodermal components. Hence, it is different from a teratoma, which contains all three germ layers. They are usually in the midline, most commonly located in the suprasternal space of Burns. Contains squamous epithelium and the material inside is also pultaceous in nature. Most common differential diagnosis is a submental or a cervical node in the neck or a midline cervical node. Submental node, if it is located, if the dermoid cyst is located in the submental region, obviously. The skin can usually be adherent to it. Excision of it is the treatment of choice. Now, congenital midline cleft is another important cleft anomaly involving the neck. So, it's because of failure of fusion of the first and second branchial walls. There is a longitudinal area of thin atrophic skin, as you can see here. Thin atrophic skin, and this longitudinal area has a skin tag above and a sinus or a fistula below. Okay, so this is excised. It cannot be straight away excised because it results in a vertical scar producing a contracture. So we might have to go for an excision with a Z-plasty. So with this, we come to a conclusion regarding this topic, which is neck sinuses and cysts, common neck sinuses and cysts. Hope I've been able to put certain important points regarding the embryology of various structures developing in the neck, and I've been able to make it slightly easy. It's not very easy, but at least I hope I've been able to make it a little easier than it was initially thought to be. All the points have been taken from three important textbooks. One is Textbook of Pediatric Surgery by RAAONLINE.co.in, Langman's Textbook of Embryology, and Inderbeer Singh Textbook of Embryology. Thank you.